Hey, Chair Creek. I got Patti Batchelder who's going to talk to you about what she does. Patti, thanks for joining us today, and the show is yours.
All right, well, thanks for having me. I am a nurse practitioner at Children's Hospital, Colorado. I work in the Department of Neurosurgery. I work at Children's, but I'm actually employed by the University of Colorado School of Medicine in the Department of Neurosurgery. And so I'm going to talk to you today a little bit about the role of a nurse practitioner, but I'm going to spend most of the time just kind of showing you what we do in neurosurgery. So a nurse practitioner is a nurse that has a advanced degree. You get an undergraduate baccalaureate prepared RN. Then you go back to graduate school and it's a master's degree. It is shifting to be a doctor of nursing practice. Many people are going back to get that, but it is still with a master's degree you can enter the field. Nurse practitioners become certified in whatever area they're working in, whether it's adult, family practice, pediatrics, there's acute care, primary care, nurse anesthetists have their own separate certification, midwives, there's various different areas that you can work. And you provide what, it's called advanced practice. Nurse practitioners and physician assistants are both advanced practice providers. You do all the functions of a medical doctor. You write prescriptions, you diagnose, you order tests, you interpret tests, and make recommendations for treatment based on that. The difference between a nurse practitioner and a PA also is a master's degree, but it's a specific PA program after you've done your undergraduate. It used to be a PA could do an undergraduate in, say, art history, and then go into PA school and become a PA. PA schools have become much more competitive now, and you have to have a undergraduate degree in some sort of biology, physiology, something related to human science. For all of us, again, prescriptive authority. The difference in a nurse practitioner and a PA is that a nurse practitioner has an independent practice. So my practice is not independent because I work with surgeons and I don't do the surgery. But I could, if I wanted to, go open a clinic and it would be my clinic, my independent practice. PAs cannot do that. PAs are always tied to a physician's license. So I have an independent license and PAs do not. They are licensed, but they're tied to the physician. So what do we do in neurosurgery? So we diagnose and treat the disorders of the brain, spinal cord, nerve, skull, and spine. And pediatric neurosurgery, we cover infants all the way from little tiny preemie babies all the way up to adults. I do still take care of some adults that have conditions that they've had since childhood. And I am old enough, and I've been at my job I've been doing pediatric neurosurgery for 28 years. 26 of those here in Colorado. So I do have patients that are grown up, and I said it's not fair because my own kids make me feel old, and then I go to work and I feel old with my patients. So we get across the lifespan. The difference between neurosurgery and neurology is that we deal with things that could potentially be treated with surgery. Neurology does things like seizure disorders, migraine headaches, developmental issues, and you'll see through the rest of this talk what we deal with. We provide care either surgically, and we also provide non-surgical care depending on the nature of the injury or illness. So when I go through some of the different diagnoses that we take care of, I don't do the surgery, but I do everything else. I do pre-op workup, I do pre-op teaching, I do post-op assessments and ordering tests, admitting patients to the hospital, discharging them. So everything else that goes on in the care of that patient, except the surgery, is what I do in my role. So just a little bit of a review of your nervous system. The central nervous system is made up of the brain and spinal cord. The brain and spinal cord are made up of neurons, and then they have support cells that are called glial cells. And the network of neurons is what provides the communication between your brain, down your spinal cord, and then it goes out through all the peripheral nerves so that your body is always talking to each other. And the messages between your brain and your body are incredibly fast. They travel at about 360 miles per hour. So that's why you say, I'm going to move my hand, and before you're even done completing that thought, your hand has done it. And much of the things that go on in your body, as you know, happen without you thinking about it. The way that cells in your body talk to each other is with chemical impulses. So every cell is made up of different degrees of sodium, potassium, chloride, and those all carry different positive and negative charges. And it's the balance of positive and negative charges on each side of that cell that the cell then changes that, and it changes almost like electricity. It changes from negative to positive on the inside to the outside, and that's how it spreads messages between the cells. And it's very, very quick. The nervous system is the most unique system in the body, but it's also the most vulnerable. When you're born, you have your full set of neurons. They continue to mature and your brain grows in size, but you cannot grow new neurons. So when you get brain damage and you damage those neurons or kill those neurons, you cannot grow them back. You can take out half of someone's liver and they will grow their liver back, but the brain is not that way. So when it's gone, it's gone. It's also very fragile. This picture here is an actual brain. So you can kind of see what it looks like. This is one that's been put in formaldehyde or something, to preserve it. But the brain is pretty soft. It's about the consistency of cream cheese, the cream cheese that comes in the square. Or if you took Jell-O and pudding and mixed them together, that would be about the consistency of the brain. So the brain and the spinal cord are really quite vulnerable to injury. But luckily, they're housed in some pretty strong bones. You got the vertebrae, which are the individual bones of your spine here that protect your spinal cord. And then your brain is housed nicely inside the bones of the skull. Another thing that gives some protection to your brain and spinal cord is what's called cerebral spinal fluid. Cerebral spinal fluid is made, we all have fluid cavities in our brain. This is what they look like. They're called ventricles. Here's how they sit. The two lateral ventricles are shaped like C's, and then the third ventricle sits below it. And then there's this little aqueduct here, and it comes down to the fourth ventricle, which sits between the lobes of the cerebellum. And then here's kind of a cross-section view of that. We all have tissue within our ventricles called choroid plexus. Choroid plexus makes spinal fluid all the time, much like your kidneys make urine all the time. The majority of it is made in the lateral ventricles, but there is some in the third and some in the fourth. It flows downhill from the lateral ventricles into the third, down into the fourth, goes down around your spinal cord and gets out over the surface of the brain. When it's out over the surface of the brain, it gets reabsorbed back into the bloodstream, and you're constantly making it and constantly reabsorbing it. And its purpose, basically its main purpose, is protection, so that when you're moving around and moving your head and your brain isn't slapping back and forth against the skull, it's floating in this protected bath of water. Spinal fluid has a lot of sodium and some glucose and some potassium in it, so it does do a little bit in helping with waste removal for cells, but its main purpose is protection. There's a lot of problems that we deal with in pediatrics with problems with spinal fluid called hydrocephalus, and we will talk about that in a little bit. Your frontal lobes, shown here in the green, is where your personality lives. That's who you are. That's your emotions, your judgment, your decisions. If you've ever heard of somebody being frontal lobish when you're a little bit disinhibited and maybe say things that are inappropriate, that's where that comes from. It is your expressive language and understanding. Memory you're going to see pop up on a lot of these slides because memory is controlled in a lot of different areas of the brain, including the frontal lobes. And then in the frontal lobe, right here is what's called the motor strip. And that's a thin band that goes across the brain on each side. That's responsible for every body part and its ability to move when you tell it to. And the right side of the brain controls the left, and the left side of the brain controls the right. The parietal lobes sit right behind the frontal lobes, and this, the front part of that, sitting directly behind the motor strip, is the sensory strip. And so that's the part of the brain that is responsible for all the sensations coming from everywhere in your body. And again, it's different parts of the body along that strip. It's your integration of senses, helps with your body orientation, visual attention, and memory. Your temporal lobes are kind of right in here, and that also has memory, mostly retrieval. This is also where your hearing gets processed. There's huge speech areas. There's a particular area called a Broca area. So the temporal lobe has a lot to do with speech, vision perception, and your ability to categorize. The occipital lobes mainly is a huge vision center. This is where your brain kind of makes sense of what your eyeballs are seeing, and reception of it and the interpretation of it. The cerebellum is the lower portion of brain. This is a more primitive part of the brain. This is balance, coordination, proprioception. Proprioception is your ability to know where your hand is without looking at it. And then your brainstem is the most primitive part of your brain, but this is also the most important. It's your autonomic nervous system, meaning it takes care of your breathing, your heart rate, your blood pressure. This is also the place that all of the two cranial nerves, the optic nerve comes off the back of your eyes, and the olfactory nerve, which is cranial nerve number 2, comes off in the back of your nose. But the rest of the cranial nerves that do things like move your eyebrows, blink your eyes, move your eyeballs, move your lips, move your vocal cords, let you swallow, let you coordinate talking and breathing and swallowing without choking on it. All of those things come off of cranial nerves, and cranial nerves, all except the first 2, all come off the brainstem there. So what happens when there's a problem with the brain? Well, you can have a very isolated, very specific part of the brain have a tumor in it or an injury to it, and you will see a very specific set of symptoms based on where that injury is, much like the cartoon here. But you can also have problems in the brain that cause overall increased intracranial pressure, and that causes more of global dysfunction in the brain. So it kind of depends on what's going on, exactly what you see, and very much so what part of the brain is affected will also dictate what you see. So in pediatric neurosurgery, the main problems that we see are we deal with tumors in the brain, spinal cord, tumors of the skull and spine, many problems with spinal fluid production, circulation, and that's hydrocephalus. Epilepsy is uncontrolled seizures that continue despite medications. And there are certain forms of epilepsy, there are certain causes of epilepsy that we can surgically remove that part of the brain to cure the seizures, or we can implant devices to help control the seizures. There's lots of vascular malformations, not just strokes by themselves are kind of more of a neurology thing, but hemorrhages into the brain. There's actually malformations in the way that blood vessels are formed that we deal with. We deal with a lot of trauma, brain and spinal cord trauma. And then there's a host of congenital abnormalities, problems that kids are born with. Spina bifida, Chiari malformation, which is a malformation in the hindbrain, and craniosynostosis, which is premature closure of the growth plates. So we're going to start with hydrocephalus. This is a baby, and this is a real baby. I took care of this baby. His head size here is the same, it was bigger than mine when he was born. Hydrocephalus can develop in an unborn fetus, and they can be born with it, or kids can develop it later for a lot of different reasons. Babies, when they're born, the plates of their skull are not fused together, and what causes skull growth is brain growth, but the skull will grow to accommodate anything that is growing inside it, including a buildup of fluid, and that's what happened in this child's case. How do we look for hydrocephalus? Well, this is a normal CT here. The white around on a CT, skull and bone will show up as bright white. The brain is gray, and spinal fluid in the ventricles, which you're seeing here, is dark black. And this is slices through the brain like this, and you're kind of looking down at it. This is the right side, this is the left side. And so these are cuts through those lateral ventricles that are shaped like C's. This is a child with hydrocephalus, and now you can see that these, again, skull, brain, but these fluid spaces are very, very enlarged. This right here, this ratty gray, that's what we call periventricular edema. And when you have untreated hydrocephalus, you can develop a little bit of swelling in the brain, and that's what that is. The most common treatment for hydrocephalus. So hydrocephalus can come from one of three ways. You can have overproduction of spinal fluid causing a problem. That's very uncommon. We only see that in tumors of the choroid plexus. You can have a blockage in one of the pathways, or say a tumor or something else that's blocking up one of the ventricles, and that way, or you can have the arachnoid villi that are supposed to reabsorb the spinal fluid not want to do their job. In any event, there's really no way to make the body stop making spinal fluid. It will always, always make it. There's no feedback mechanism that says, hey, cut it out, we have enough. And what happens is exactly what's seen in this CT here, is that the spinal fluid will build up. The most common way to treat that is with a shunt, and this is a picture of it here. Typically, where we placed it, it's a VP shunt, or ventricular, being in one of the ventricles, and then the tubing is tunneled underneath the skin down into the peritoneal cavity. That's where the P comes from. And it's basically a one-way pressure valve. The pressure in the head reaches a certain point. That triggers the valve mechanism to open up. The pressure in the head then comes down to another point, and it causes the valve to then shut. We always use valves that have anti-siphon devices in them as well, so that they will work pretty much the same whether you're upright or laying down. The tubing is made out of a silastic polymer, and it's really soft and flexible. It is soft, the tubing itself is about as soft and flexible as a nice soft rubber band. The valve itself is also made out of a nice soft plastic, but it's not stretchy in the way that the tubing is. This is the ventricular catheter. This is the catheter that actually goes through the brain, then the valve, and then this is what's called the distal tubing. This is that same child there with before his shunt was placed and then after his shunt was placed. You can see that those fluid spaces have come down. This is what the shunt looks like on a CT. This then now becomes a baseline for that child. And when the child comes into clinic, we pretty much every day in clinic, I'm seeing somebody that has a concern about shunt malfunction. One of the things that we do is get an image and make sure that the ventricles are not getting any bigger. Another way that you can treat hydrocephalus is what's called an endoscopic third ventriculostomy. And this is a way that provides a bypass in certain patients to allow the CSF to get out to the subarachnoid space and get reabsorbed by those arachnoid villi. So obviously this won't work for every type of hydrocephalus, but it does work for patients like this guy here, who has a block right here between the third ventricle and the fourth ventricle. His lateral and third ventricles are very enlarged. Here's those lateral ventricles and this the third ventricle. There's a block here, but his fourth is normal. So in an endoscopic third ventriculostomy, the surgeon comes in with an endoscope. Here's a picture of it over here. Identifies the floor of the third ventricle. And this is what it looks like when he's coming in. And believe it or not, there's a thin membrane right in there, and that's the third ventricle. And then he basically, or that's the floor of the third ventricle. And then the surgeon pokes a hole in it and has created a new pathway, because what he's doing is creating a pathway right here. And then that allows the spinal fluid to bypass this whole section and get out up here and get reabsorbed. You have to be able to see through the floor of the third ventricle. These are two things here are called mammillary bodies. And that dark thing in the middle, that's a big carotid artery. So you don't want to go poking blindly. And here you can kind of see there's those mammillary bodies and there's that artery right there. Sorry, not carotid, it's the basilar artery. I misspoke. All right, so that's a quick overview of hydrocephalus. This is an example of trauma. This is a X-ray here and a CT here. And you can see kind of right here the area of the depressed skull fracture. And here it is on a slice of the CT pushing in. And this is that same child at presentation. This was an open skull fracture, so it was open to the air over it. That's bone sticking out right there. That's what the fracture looked like at surgery. This is the rest of the skull. And then we just basically plated it back together. These are titanium plates and screws. Then you close the skin back up and the kiddo is good as new. This is an example of a spine fracture. This is X-rays here, and you can see the bones coming down, and oop, something's wrong there, then they keep going. This is that same patient's MRI. And so here is the body of the vertebrae. This is the spinous process, the bump that you can feel when you run your finger up and down your back. And then here's the spinal cord. This child was actually in a car accident, unfortunately, with a drunk driver, suffered this fracture here. And you can see that the spine basically cut completely through and cut the cord. So he is now a paraplegic. He has no feeling or sensation from about right at the bottom of his ribs down. And this is the same MRI. This is the spinal cord coming down, and you can see the spinal cord over here, spinal cord over here, spinal cord over here. So the spinal cord was completely torn. So this child, there's no way to regain that function. We talked about how vulnerable the brain and spinal cord are. And in traumatic situations, the same bones that protect them normally can sever through them as well. He underwent a spinal fusion, and that's what this looks like. These are titanium rods placed to put his spine back together. This is his post-op X-ray showing that instrumentation, and you can see that the bones of the spine are pretty much back in alignment. And the bones will heal and his spine will be nice and straight again, but his spinal cord will never function again. And that's part of the problem. Like I said, when you hurt your brain or spinal cord, there's only so much we can do to help that. So you got to be smart and protect them as well. This is an example of a traumatic brain injury. This is one of the harder aspects of my job. We do have to deal with a lot of child abuse, unfortunately. Again, excuse me, this is that normal head CT here. This is the baby when he first came in. There's blood here, and you can see how on a normal CT, you can see the ventricles right in the midline. And over here, you can see that this ventricle on the right-hand side is being compressed. That's because there's this bleeding out over on the surface of the brain here. The brain also looks different in through here than it does on the other side. There's what we call ischemia, or lack of blood flow and swelling there to the brain. This is that same brain a few days later, and you can see that the brain has turned very dark. That is a very, very bad sign. That means that that brain is dying. There's a lot of swelling in there. And then this kind of white stuff that we see in here is what's called laminar necrosis. And that's as different types of cells and byproducts are depositing in the brain as a result of that severe injury. You see it more pronounced on MRI here. And then this is that same baby, probably about a year, 9 months to a year later. You can see that all of that brain, where it should be brain, it now looks the same signal as spinal fluid in the ventricles. And that's because that entire brain has died away. So this poor baby was the victim of abuse and lived, but basically has no function. Congenital defects. This is an example of some spina bifida. Most people think of spina bifida, they think of the big sac on the back, and children that are born and unable to go to the bathroom by themselves, move their legs. There's varying degrees of it, and that basically at whatever level the spinal cord didn't form normally, from there down is where the children don't have normal function. This is what a myelomeningocele, this is the most severe form of spina bifida. It can look like this, or it can have a big thin skin bubble over it that has spinal fluid underneath it. But basically when a fetus is forming, you have dad cell and you have mom cell, and they come together and they divide and differentiate and become a human being. By about the 4th week of gestation, the little lima bean, if you've ever looked at fetal embryology, develops a groove on the back of it that deepens, and then the edges come up and fuse. That becomes what's called the neurotube. The neurotube then goes on to form the brain and spinal cord. If that tube fails to close, and again, by 4 weeks, it's either closed or it's not, that's how kids end up with varying degrees of spina bifida. That's also how some babies are born with what's called anencephaly, where their brain didn't form normally. And so this is basically myelomeningocele. This over here is what's called a lipomyelomeningocele. You can have fat and skin covered over it. This is what this child looked like at operation. All this yellow stuff in here, that's all fat. And basically what the surgeon is trying to do, we can't change this immature tissue that didn't form appropriately, but you basically try to fold it in on itself and return the child to a normal contour on their back. And again, here's another situation where the child is born with not full function of their nerves, and because from that level, the spinal cord down, it doesn't function properly, and we have no way to fix that. Most kids with spina bifida also end up with hydrocephalus, and that's because they have what's called a Chiari malformation that ends up disrupting the way that spinal fluid flows. One of the things that has helped kids that are born with being born with spina bifida is fetal surgery. So this is a picture right here of fetal surgery, and the neurosurgeon and a specially trained neurosurgeon and a specially trained pediatric surgeon do in utero surgery. And this is mom's uterus here, and the uterus has been cut open. And this is actually the baby's back, and right here is the spina bifida defect, the myelomeningocele. And so the pediatric surgeon opens the uterus, and then the neurosurgeon closes this defect. It doesn't change the fact that the kids still have neurologic dysfunction in their lower extremities, in their lower legs, ankles, feet, toes, and dysfunction with controlling their bowel and bladder. But what fetal surgery has done is decrease the number of kids who end up with a Chiari malformation. So it has decreased the number of kids that end up with hydrocephalus and needing a shunt, which is a very important thing, because shunts are lifelong and they're plumbing, they can malfunction. So we spend a lot of time in neurosurgery dealing with shunts. All right. Epilepsy surgery, like I said, epilepsy is continued seizures that happen despite various medications being tried, and often multiple medications. Kids will continue to have seizures. Some kids can have up to over 100 seizures a day. some can be having lots and lots of seizures every day, and they can be small and quick, but they're having so many of them that it's disruptive. Other kids could have really big, grand mal, long seizures, and maybe they only happen once a month or, once every couple of months, but they're still very disruptive. They can't drive. It has a huge impact on their life. So kids with epilepsy will undergo a very extensive workup. And what you're doing in that workup is you're looking to see if the seizures are arising from a certain part of the brain. And if they're arising from a certain part of the brain, is that area an area that can be resected? And this is an example of a child. This is the CT here. And you can see this kind of these calcifications here. This was an area of what's called cortical dysplasia, specifically on this patient. And first you do imaging, looking for an abnormality. Then you do extended EEG monitoring to see if it looks like not only are the seizures all coming from this right side, but can we tell if it's coming from that area? An EEG on the scalp is a little bit distorted as it passes, as those brain waves pass through not only brain tissue, but the spinal fluid and the skull and the skin. And so you can't quite pinpoint where that seizure is arising. And the last thing you want to do is just go in and hack out this portion of the brain only to find out that maybe there's somewhere over here that's giving that patient seizures as well. So there's what's called phase 2 monitoring, which actually involves an operation. Here's the brain here. We open over the area where we think the seizures are coming from, and you can lay the electrodes or grids on the brain. Then you close the skin back up. This is what it looks like on X-ray. And then the child sits in the hospital and gets monitored. This is kind of the old gold standard of how to do it. What we do way more often now, and let me see, is what's called stereo EEG, where we use a robot and just put a bunch of electrodes in. This allows us to do this bilaterally, so we can make sure there's no seizures coming elsewhere. This lets us get electrodes deep into the brain, close to where we think it is. And technology has always been around, but an operation to place this many electrodes would take forever. So with the intervention of the robot, basically doing very rapid, what we call stereotactic or very precise trajectories, lets you complete this operation within a reasonable amount of time. Then the child is monitored and we pinpoint where those seizures are coming from. And if they're coming from the place that we think we are, then we take the child back to the operating room and we resect the seizure focus if we can. So this child got his seizure focus resected and he became seizure-free after that. And I believe he's far enough out now, he came off of medications. The success rate for epilepsy surgery depends on the type of epilepsy surgery that you're doing and what you're doing it for. So for example, hemispherectomies, where we go in and basically take out part of one hemisphere and disconnect it, for those kids that need it, that actually, believe it or not, carries the highest chance of becoming seizure-free. Kids like this who have a lesion very focal tend to have very good results, but the problem for him that he still runs the risk of having seizures because cortical dysplasia often involves more of the brain surrounding it than we know. So those, there's still a chance that his seizures could come back, unfortunately. All right. Pediatric brain tumors, they are the most common solid tumor in children. They are the second most common form of cancer in kids, but it's second to leukemia, and tons of kids get leukemia. Not as many kids get brain tumors. So it's about 2,000 per year. And so not big numbers, but to us it's big numbers because that's what we do. Brain tumors in kids are very different from tumors in adults. And when you're dealing with brain tumors, so you can have, there's certain types of tumors that occur only in children. And then there's some tumors that do occur in children and adults, but they behave differently when they're in the pediatric brain than in the adult. And when you're dealing with brain tumors, it's not as simple as, is it a malignant tumor or a benign tumor? It's really like real estate. It's all about location, 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 because you can have a benign tumor, but in a bad part of the brain that you can't go in and resect it, and it will ultimately kill you. Or you could have a super malignant tumor, but if it's in a good location of the brain and you can fully resect it, then you have a much better chance of surviving that. All right, so here's some examples. These are MRIs that we're showing here. And this is the brain here. This child has hydrocephalus because of this tumor that's sitting right here. This is a tumor that arose in the fourth ventricle. The part of the brain that is the brainstem and the cerebellum is called the posterior fossa. And so this is a posterior fossa tumor. Posterior fossa tumors are way more common in children than they are adults. This is what that tumor looked like at surgery, cerebellum, cerebellum. Here's the tumor kind of poking out of the bottom of the fourth ventricle. This is another example of a posterior fossa tumor. This one is with contrast, so that all of this bright stuff here, that's all tumor. And you can see that the tumor is filling that whole posterior fossa. And there's some, I don't, if you can appreciate it, there's some contrast enhancement here. This is a tumor that's actually, it's hard to know, and I know because we operated on this child, but this was actually a tumor that was arising at the back of the brainstem and going out and filling into the fourth ventricle. This is just a picture of a tumor sitting very close to the surface of the brain. This is the normal brain and some of the blood vessels on it. And then you see this structure right here, that's a tumor. This is another tumor, those little pearly white things in there. This is a tumor that was kind of, if you look at my crosshairs here, kind of back way behind the eyes in the brain, in an area where you have your optic nerves. There's a lot of blood vessels in there. And there's the tumor in there. This is another MRI showing a very large tumor. This here on the left side is what normal brain looks like. There's the ventricle, and you can see that it's getting pushed over. This would be the midline line of the brain going up and down here. And you can see that this huge tumor here on the right is pushing everything over. This is what's called a craniopharyngioma. This is a tumor that occurs right where I was talking about with that last tumor. These are benign tumors, and if you could resect the whole tumor out, you would cure the patient. They're very slow growing, so that chemotherapy doesn't really work on them because chemotherapy works by killing cells that are rapidly dividing. And so this is an example of a benign tumor in a very bad location because your optic nerves are there, you have big blood vessels there, but more importantly, it is a tumor of what's called your pituitary gland. And your pituitary gland controls all of the hormones that regulate things in your body. So it controls the natural steroid that we make that controls things in our body. It's your growth hormone, it's your thyroid hormone, and the hormones that control how much salt and water that you keep in your body. So, oops, where'd it go? There it is. So it's a very bad location to have a tumor. Here is the big carotid artery coming up. This is the optic nerves on each side. And then there's that tumor kind of sitting behind it, just bulging it forward. This is, of course, the surgeon's slide, and he's very proud of himself because there's the resection cavity for that tumor. So this was one that you can almost they got a fair amount of it, but a lot of times you end up leaving the capsule of that tumor behind, and that can go on to cause some problems later. Sorry. All right. So you can also get tumors in the spinal cord. You can have primary tumors in the spinal cord, but there's certain tumors in the brain that will metastasize to the spinal cord. So here's a big ugly tumor in the posterior fossa here, and it is an example of what's called drop mets down here. So in a child like this that's got this big invasive tumor, and you know that it's already metastasized within the central nervous system because he has a spot on the spinal cord, the surgery is helpful in this regard in debulking the tumor, but you're not going to go after this little spot on the spinal cord. These are kids who depending on the type of tumor, it can then be treated with either chemotherapy or radiation. Radiation is a little bit tricky because you're radiating the brain and the spinal cord. And even if you do focal or stereotactic radiosurgery or gamma knife, you still are damaging surrounding brain around that. And kids who, like this child who ended up getting cranial spinal radiation, radiation to the brain, the whole brain, is not very good, and it will, even in adults, lower your IQ. Particularly in the developing brain, so children under 3 really aren't even a candidate to get radiation unless they absolutely have to, because it will have a devastating effect on their cognitive abilities later, unfortunately. So also in neurosurgery, we do have some fun tools. I mentioned it a little bit with the stereo EEG. We use image-guided surgery or stereotactic, where you take imaging, and in this case, this is an MRI. There's multiple different systems out there, but you put the imaging into that system. This is what a head holder looks like when the patient is in surgery. They're asleep, but the head is held so that it can be draped and exposed and not move, obviously. And then there's depending on the system, it has registration, so that no matter where you put a instrument, you will get an updated picture of that patient's scan. So it allows you to, for example, in a tumor, it allows you to make a smaller incision and know exactly what trajectory to go into to find that tumor. It's used when we're trying to place shunts into ventricles that are very small. It's used when, with the stereo EEG, the robot basically is a navigation system, and very quickly, based on the surgeon's plan of where they want all those electrodes to go, will move its arm around, and it'll be like, put one here, put one here, put one here, put one here. The surgeon is actually placing it, but the robot is showing the trajectory. And the robot is a marriage between the image guidance system and the programs that it has in itself. So that has made brain surgery a lot safer, but we're also still limited by the fact that there's just certain places in the brain that you can't resect things. We can also do an awake craniotomy. So say this patient had this lesion right here. And when you see from the side, if you remember that picture that we showed of the frontal lobe, this was intimately involved with the motor strip. So in an awake craniotomy, the child goes to sleep, but not as fully deep into anesthesia as you would normally put someone. They're put in the head holder, they're positioned, they're draped, the skin is open, the skull is open, and then they wake the patient up. We use EEG to map out and monitor what we can. If we're testing the motor strip, the patient doesn't have to be fully awake. They just have to be awake enough that their their limbs can move. And then we use like an EEG, but instead of recording the brain, we stimulate it. And we stimulate it and basically map out, okay, this part makes his foot move, this is where the toe is, this is the knee, this is the hand, whatever it is that is around that lesion. And then once the surgeon knows where those things are, he can try to do a very tailored resection, sparing those parts. You can do this for places with speech too. Patients can be woken up enough in the middle of their craniotomy to name pictures, talk to somebody, answer questions, whatever part of their speech in that area that we're worried about. We use a neuropsychologist is who comes in and gets up under the drape there and talks to the patient. Obviously, there's an age limit to this. You can't do it with a toddler or a baby or even a very young preschool, but school age on up, they could be a candidate for that to make the surgery safer. We do use lasers in neurosurgery. We have the ability to do laser ablation. So small lesions that are either small circular lesions or lesions that are a little oblong in shape can be treated with a laser. And again, you're using image guidance and the laser. This is what the laser looks like when it's going in. These are pretty labor intensive operations because you're going back and forth between radiology, but the laser is put into the lesion and then fired. And it's pretty interesting that the energy of the laser will stay right within the lesion. It doesn't spread out into the brain. And this is kind of what that imaging is showing here. And this is after the with the actual firing of the laser. And you could do it, you're limited by size, but you can do focal burns kind of in a row, and that's where you can laser the a more linear shaped lesion. And this is post-op laser ablation. This is what the lesion looked like preoperatively. This is an MRI. This is the brain. And this is in the cerebellum. Actually, you can see how the brain looks a little different than the surrounding brain. And then this is 6 months after. So the lesion is still there after you've burned it, but then it kind of dies away and leaves almost a scar there with that. And that is about it. I would ask if there's any questions, but I guess those will get forwarded to me at a later date.
Yeah, where I will put the video, there's a place where they can type in questions at the end, and I'll send you an email. And
awesome.
Then they can go back and read what the question was as well as what your response was. So great job with the presentation. Everything looked perfect on it. Everything worked very well, and good color.
Did it show, because my presentation went away for a minute when I was like, oh, it's gone. Could you see that in the video?
No, there was one where it like paused for a second, but like the pictures themselves never went away.
Huh, well, that's good.
Yeah.
I'm probably like, what is she talking about? They'll be like, what is she talking about?
So I'm going to stop us on recording, but Zoom.